So I ran to pull the Ativan, but the neurologist stopped me. He said, "This is not an epileptic seizure." I was like, then what is it? Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Hello, everyone, and welcome to another episode of the Rapid Response RN podcast, where we dive into the complexities of nursing care and high-stakes situations. Today, however, we're tackling a little different but still important and often misunderstood topic, and that is psychogenic non-epileptic seizures. This episode, I want to share with you not one, but 3 stories that have helped to inform my understanding of psychogenic non-epileptic seizures. So the first dates back to when I was in nursing school. I had clinicals on the neuro floor, and they had a few beds that were designed as seizure monitoring beds. Patients with seizure-like activity would be admitted there, placed on continuous EEG and video monitoring, and they had specifically trained EEG and video monitoring seizure techs who watched the patients and would interact with them remotely to gather information about the seizure symptoms and clinical data. Patients would tell the tech via video when they were having an aura and describe their symptoms both before and after the seizure episode. There was this one young woman admitted with seizure activity and was diagnosed with what was termed at the time as conversion disorder. Now, we don't call it that anymore, and I will address the importance of proper terminology later, but this was 22 years ago, y'all. So that was the approved medical diagnosis then. I remember getting a report from night shift with my nurse preceptor and having never heard of this conversion disorder. And when the off-going nurse said, "She has conversion disorder," I must have made a face showing that I didn't know what she was saying. So she looked at me and said, basically, she's faking it. She doesn't actually have seizures. It's all in her head. Being young and impressionable at the time, I'm so grateful for what happened next. The nurse who would be training me that day showed me how to pivot the conversation and advocate for this patient. My preceptor then said to the off-going nurse, "Did you not read the chart? I had her 2 days ago when she was admitted, and her seizure episode started after she saw her brother shot and killed in front of her. She's not faking it. She can't control it. This is her body's way of responding to the trauma she experienced, and it's not our place to judge, but rather to provide care and support as she navigates the challenges of this condition. Now that we've determined it's not epilepsy, that's good news, and we can help her get the treatment that she needs." She shut that down real fast, and her ability to advocate for that patient has always stuck with me. The next patient I want to share with you was one that I cared for in the ER. It was a young man in his 20s that had epilepsy and took anti-epileptic medications for his seizures. He came in having what looked like a seizure to me. His arms and legs were shaking and his eyes were clenched closed, and he was not responding. With his seizure history, we gave him Ativan, and eventually the seizure stopped. The hospital was full, so he ended up staying with me the bulk of my shift in the ER, even though he was already admitted. He had 2 additional seizures, for which I gave Ativan, but then when the second one happened, conveniently, it was when the neuro team was rounding to see him. So I ran to pull the Ativan, but the neurologist stopped me. He said, "This is not an epileptic seizure." I was like, then what is it? He responded, "It's a pseudoseizure." Again, no longer using that term. We should be using a different one. But I pushed back. "Doesn't he have epilepsy?" He said, "Yes, he does. I see him in clinic. But he also has pseudoseizures, and this is not an epileptic seizure." So I clarified. "So you don't want me to give the Ativan? Is there anything that I can give him?" He said, "No, he'll stop eventually." He was not the kindest and just talked over the patient, pointing out aspects of the seizure like the symptoms that showed he was not having a seizure. He said, "See his eyelids? They're clenched tight. Epilepsy doesn't cause that. See the non-rhythmic movements of his arms and his legs, his hips thrusting? Epilepsy doesn't present that way." I felt so helpless. My patient was obviously suffering and there was nothing I could do to help. So I just went up towards his head and said, "Hey, Chris, I'm here with you. I know this is scary. I just want you to know that you're safe and all of your vitals are looking okay. The neurologist thinks that this will stop on its own, so I'll be here with you to monitor you and make sure that you're safe until this episode passes." Within a few minutes, his symptoms subsided and he returned to his neurological baseline without any intervention. And then the last story was actually not a patient, but a visitor. So I responded to an emergency, a bradycardic patient, and the patient's daughter showed up right as everyone was running into the room. She was clearly emotionally overwhelmed by all the commotion in the room and the emergency her father was experiencing. She was pacing in and out of the room and had her sister on speakerphone trying to relay all that was happening, but it was just adding to the chaos of the room. Since my rapid response partner, Marissa, was with me for this rapid, she could handle the patient without me. So I stepped out to talk with the daughter and try to provide some explanation of what was happening and help her process it all. As I was explaining everything to her, the patient's daughter says to me, "I'm going to have a seizure. I'm going to go to the bathroom and have a seizure now." And I was like, "Okay, I will stay with you, but I don't think the bathroom is the safest place for a seizure. There's just so many hard obstacles in the restroom that could cause injury." So I tried to direct her to a close by family waiting area because there was no open rooms. And I said that I would stay with her and make sure she was safe and that I could get her to the ER if the seizure lasted too long. She kept repeating to me that the seizure was coming and she could feel it. So I asked the nurse tech to bring me some blankets. I encouraged her to sit on the floor with me in the hallway outside of her dad's room, and I put blankets around us to help pad her and keep her safe. I asked if she has seizures and if she has something she could take when she feels a seizure coming on, or if I needed to get her to the ER or get the ER to bring me a stretcher. I didn't feel comfortable transporting her in a wheelchair with this potential seizure that could happen any second. Then her husband arrived, and he explained that she's had these seizures for a year now, and no doctor will prescribe her anything for her seizures. I had my suspicions, but that's when I knew that she probably had psychogenic non-epileptic seizures. So I said, "If you don't want to go to the ER and you don't want to go to the waiting area, I will stay with you and monitor you here. Can I put a pulse ox probe on your finger just to monitor your oxygenation?" And she consented. Then I just put my hand on her back and sat on the floor next to her. She started having this rhythmic jerking in her upper and lower extremities. I had the blankets laid out, and someone had brought me a pillow for her head. She had the episode for a few minutes, but her oxygen saturation was good the entire time. Her skin appeared well perfused, and I didn't see any signs of airway compromise. I stayed down on the floor with her and just kept reminding her, like I do with every patient who has a psychogenic seizure, that she was safe and that I was with her, and in this case, that her dad was also okay and his heart rate was improving. Then, someone arrived with a stretcher that they had retrieved from the ER. Her jerking subsided, and she woke back up, and I asked her if she wanted to get in the stretcher that they had brought for her. She agreed, got up in the stretcher, and then had another episode. This one lasted, 3 to 5 minutes. Now, mind you, all of this was happening in the hallway of the cardiac tele floor. She was not a patient. She did not have a room. So when her second episode started, I said to her, "Hey, if these keep occurring, I think we're going to have to take you to the ER. The staff on this floor cannot care for you and your dad, and I want to make sure that you are safe. So I'm going to head to the ER now." Then her second episode subsided, and she didn't want to go to the ER. She said she just wanted to go outside and get some air. I offered to go with her. We got outside. We sat on a bench, her and her husband and me. She thanked me profusely and said she would be fine. She has these all the time, and she'll be okay without me. So I gave her husband the phone number to call for a rapid response if he needed, and he stayed with her, and I returned to the patient's room on the cardiac tele floor to see if I could help. Marissa had already wrapped things up there, and the patient was stabilized. As you can imagine, All the cardiac nurses who don't deal much with seizures were quite confused and had a lot of questions when I returned. What was that? Was she really having a seizure? Why didn't we give her Ativan? Is she going to be okay? All great questions that I hope to answer in today's episode. But before I do, I want you to know that this woman came back to the hospital the next day with an edible arrangement. You know, the fruits dipped in chocolate in a bouquet. She wanted to thank me for helping her through her seizure. The moral of the story, all three stories actually, is that patients with psychogenic non-epileptic seizures may not be experiencing abnormal electrical activity in the brain, but they are experiencing something that needs our support and not judgment. So let's dive in. To begin, what are psychogenic non-epileptic seizures, or PNES, which is the most unfortunate acronym? I used to think it was cabbage, or coronary artery bypass graft, or TACO for transfusion-associated circulatory overload. Those are fine just to pronounce as one word, cabbage, TACO. But for clarity, in this case, make sure to spell out each letter. It should be pronounced PNES, not penis. Psychogenic non-epileptic seizures are events that resemble epileptic seizures, but are not caused by any abnormal electrical activity in the brain. Instead, PNES is classified as a somatic symptom disorder, often linked to psychological distress. It's important to emphasize that patients with PNES are not faking it. The episodes are involuntary and very real to the patient. PNES is frequently underdiagnosed or misdiagnosed. In specialized epilepsy centers, about 20 to 40% of patients initially diagnosed with epilepsy are found to have PNES after their detailed evaluation. Unlike epilepsy, which is a neurological condition, PNES falls under the realm of psychiatric or behavioral health. Common triggers for PNES are past trauma, such as abuse, especially sexual abuse, chronic stress or anxiety, and depression. These factors often coexist with PNES and can complicate the patient's clinical presentation. So next is, how do we differentiate PNES from epilepsy? Hey guys, I just wanted to take a quick break to talk about something that I think is really important, and that is getting certified in your nursing specialty. Not because having the extra letters behind your name make you a better nurse, but because taking the time to deep dive into all that you need to know for your specialty, putting in the study hours, and dedicating yourself to mastering what your patients need you to know how to manage them best, the prep for the exam, is what will make you a better nurse. So whatever specialty you are currently working in, go study for that certification exam. And if you're a critical care nurse, I have something that will help you pass your CCRN. My friend Nick McGowan has an excellent online self-paced CCRN prep course called Critical Care Academy. It is so thorough, and he has broken down everything you need to know into little bite-sized digestible content that he calls micro-learning. Let me tell you, the CCRN is the hardest test I've taken in my entire life. You don't want to go it alone. You want to take this course to ensure that you know your stuff before sitting for the exam. If you'd like to check out his course, you can find it at ccrnacademy.com. And great news, just for being a Rapid Response RN podcast listener, you get 10% off the cost of the course by using the coupon code RAPID10 at checkout. So if you've ever considered getting your CCRN, do it. And let Critical Care Academy help make sure that you will pass. I'll put the link and coupon code in the show notes. Well, in the clinical setting, it requires careful observation and history taking, but there's some key differences between PNES and epilepsy. So here's what we've learned to look for. As far as the clinical presentation, PNES episodes often have a prolonged duration, lasting 5, even 10 minutes, and they kind of wax and wane with their intensity. Patients may maintain consciousness or show like atypical movement patterns, such as a side-to-side head movement or pelvic thrusting. Those types of symptoms are not typical for epilepsy, but really only seen in PNES. Epileptic seizures, on the other hand, typically show a very predictable pattern, such as tonic-clonic, very rhythmic activity, and they usually only last 1 to 2 minutes, except for obviously status epilepticus lasting 5 minutes or longer. So patients having a seizure will actually have their eyes open or slightly open, while patients having a psychogenic seizure will often have their eyes shut, maybe even tightly shut. With regards to tongue biting, typically a bite on the side of the tongue is more suggestive of epilepsy, whereas a bite at the front of the tongue could potentially just be indicating PNES. And as far as incontinence goes, well, that's not a helpful indicator of either one. Patients with PNES may or may not experience incontinence, and patients with epilepsy may or may not experience incontinence. So don't look for incontinence to tell you one way or the other. The next is the post-ictal state. So after an epileptic seizure, patients usually experience a post-ictal state, which is marked by confusion, fatigue, lethargy, whereas in PNES, the patients may recover more quickly with less of post-ictal confusion. And then there's triggers. So PNES episodes are often triggered by emotional distress or some sort of external stimuli, whereas epileptic seizures usually occur randomly. And as far as triggers go, maybe things like sleep deprivation or flashing lights. And then finally, EEG findings is the gold standard for diagnosing PNES versus epilepsy. So obviously during an epileptic seizure, the EEG will show abnormal electrical activity, whereas during a PNES episode, the EEG will look normal. How are patients ultimately diagnosed with PNES? Like I said, the gold standard is the EEG, but let me walk you through how that works. And I kind of mentioned it a little bit in the case from earlier. Remember, the young woman was admitted to the Epilepsy Monitoring Unit, or the EMU, and over the course of several days, we observed her during an event, and while her movements looked like a seizure, the EEG remained completely normal. And this was a definitive clue that she had PNES. So here's the general process for the diagnosis. Clinical observation, so the patient's admitted to the EMU, episodes are observed alongside video and EEG monitoring. It's a multidisciplinary approach. The diagnosis should involve neurologists, psychiatrists, psychologists, all working together. Psychological assessments can help to identify some of the underlying trauma or stressors that might be leading to these PNES symptoms. And then patient education is a huge part of it that's going to be ongoing even after discharge. So once PNES is diagnosed, education is critical. Patients often feel relief knowing that their condition has a name and is treatable, and nurses play a key role in explaining the distinction between PNES and epilepsy in an empathetic and non-judgmental way. And that is why words are important when used to describe these symptoms. So we really don't say conversion disorder anymore. And we no longer want to use the term pseudoseizure. Pseudo meaning false, fake, spurious, or a sham. That can be very hurtful to someone who is genuinely not faking their seizure-like activity at all. Their body is reacting in this very scary way, and to be told that they're faking it is so invalidating and does not contribute to their move towards healing and recovery. Instead, using the term psychogenic non-epileptic seizure, though it's a mouthful, does explain both the origin of the symptoms as well as it's comforting to know that it's non-epileptic and therefore not harmful to the brain when episodes are prolonged, like in status epilepticus. Now, before we move on to the treatment of PNES, I wanted to give a quick aside. While I agree and have seen it to be true in patients that I've cared for who have PNES, that the movements are uncontrollable and they truly are not faking it, I don't want you to think that I'm this Pollyanna who only sees the good in people and won't acknowledge manipulative behaviors when I see them. We had this one patient who was somewhat of a frequent flyer in our ER, often brought in by law enforcement, and she was just a handful every time. And when she was in the waiting room and wasn't getting taken back to a bed right away, she would tell us, "Well, I'm going to have a seizure, then you'll have to put me in a bed." She would flap her arms and legs and yell, "I'm having a seizure, and she's not helping me," in the waiting room. She'd put on this big scene trying to get bumped up in line to get back to a bed faster than the other people who were also waiting in the waiting room. Now, with the same level of empathy, but a bit more firmness, I would walk over to her and say, "Mrs. K, that is not a seizure. You're okay. You really should get back in the chair. I will gladly get you a blanket while you wait, But an episode like this does not mean you need a bed ahead of all these other people. We will take good care of you, but you will have to wait until a bed opens just like everybody else. She would then get back up and sit down in the chair and often ask for a turkey sandwich to go with her blanket. So yeah, of course, there are those folks too. And I imagine every ER has a few that you know well. But guys, that's not the majority. So let's not group people like Miss K and people who are having an uncontrollable physiologic response to a psychological stress or trauma into the same bucket. They are not all pseudoseizures. Psychogenic non-epileptic seizures are treated differently. So, how do we treat PNES? Well, managing PNES requires a holistic approach. It focuses on the patient's psychological well-being, and treatment is very similar to other therapies that promote mental health. So there's therapeutic interventions like cognitive behavioral therapy. That is the cornerstone of treatment. And there's trauma-focused therapies that might help patients who have a history of abuse or PTSD. Medications, they don't need anti-epileptic drugs, but rather medications that would help with coexisting conditions like depression and anxiety. Those might actually help reduce the PNES episodes. I want to encourage patients to establish a strong support network and provide training education to those people in their network. And of course, referral to a counselor or a psychiatrist can provide additional tools for managing stress and some of the triggers for PNES. With a good therapist and good support system, patients with PNES will experience fewer and fewer symptoms. They can learn what triggers they have and even start to recognize when an episode's coming on. Much like an anxiety attack, they can get to a safe place and implement various techniques like deep breathing and mindfulness, sometimes medications to help with anxiety and depression, along with some lifestyle modifications, can reduce or even prevent PNES episodes altogether. So here are a few closing thoughts to summarize all that we've talked about today. PNES is a complex condition that requires understanding, compassion, and a team-based approach to care. As nurses, we're often the first to identify these patterns and advocate for the appropriate workup and referral for our patients. By being informed and attentive and non-judgmental, we can make a significant difference in the lives of patients with PNES and help their families be supportive as they navigate this therapy. This is a real condition, and it's not discussed often enough. I don't think I remember learning about it in nursing school. But I personally love learning about both the science and the heart of nursing. And this episode really highlights the nurse's role in caring for the whole patient. So thanks for tuning into this episode. And if you found it helpful, please share it with your colleagues. And don't forget to subscribe so you never miss an episode. Until next time, stay curious and keep making a difference out there.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. RNegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.